Hello, everyone. It's a real pleasure to be here to discuss the results of a very important study, the GASTRIPEC trial that was recently published in the Journal of Clinical Oncology. And just before starting, we have to congratulate really Peter and Beate that conducted this important study. We all know how it's difficult to conduct in Western countries prospective randomized trials on esophageal cancer. And they have to really be congratulated. So perhaps we can start with some question and start by the beginning. Can you, Beate, tell us when the trials was conceived and what was your initial idea?
So the initial idea of this trial was that peritoneal metastatic gastric cancer had a bad prognosis, and we wanted to look if we can improve in these patients. We had metastatic gastric cancer. There was lots of literature available, but it was always included somehow peritoneal metastasis. You didn't know really how much, and the situation to measure a progressive disease or improvement after chemotherapy was very difficult in these patients. And there was no one single randomized trials concerning exclusively peritoneal metastatic disease. So we didn't know what this what treatment of these patients means. It was always peritoneal carcinomatosis, fingers off. Don't do it. Yeah, it's not worthwhile to do. And but then we learned from metastatic disease that perhaps if you can remove every single metastasis, the prognosis improves of the patients. But we also know that peritoneal metastasis was worst prognosis from all of metastatic sites. So this was behind that we just said, okay, we will have a first up, we have a laparoscopy, and then we have a biopsy, a proven situation. And we have not only cytology positive, but it has to be histologically proven metastasis. And then we included preoperative chemotherapy because we thought this has to be included, because otherwise the oncologist will not go for it. Only surgery, only HIPEC is not worthwhile in this situation with an locally advanced gastric cancer with metastatic disease. And this was the situation, because this was very difficult to get people convinced by an idea to have a randomized trial in these patients. It started with 2009, and I must say Peter Schlag, who was the former chair of our unit, he started to develop this randomized trials, and really had to work hard to get people convinced to fund this kind of trial. So when it was funded, he was nearly for retirement, and then also there was things changing. In the meanwhile, we had a little bit of literature. So we started again, Peter and I, we had a new amendment of the trial, and then started to get first patients in 2013. So this was a little bit time schedule for this kind of trial. And then we had recruitment. We should have had 5 patients a month, but we only had 2 to 3 patients a month. And this was also, people came after. Oh yes, I opened the patient who was peritoneal, but can he take part in the GASTRIPEC trial? I said, no, unfortunately not. So we lost again. So this was a little bit the story behind this. So the recruitment was very difficult to get this study running in Germany has to be a lot of advertisement, and well, Peter and I, we were pushing the trumps to get patients in, but it was quite difficult to do so. So this is the story about what was the idea behind it. Peter, do you have any other comment?
Yeah, because we have the surgical point of view, so maybe the medical point of view will be a little different. So Peter, what was for the medical oncologist the principal goal of this trial?
Well, I totally agree that peritoneal metastases and peritoneal carcinomatosis in gastric cancer are very, very important. Even in the curative setting, if you do a laparoscopy, we know that about 20–25% have undetected peritoneal carcinomatosis, which we detect in the presence of no signs in the CT scan. So it's a high medical need to treat peritoneal carcinomatosis. On the other side, we know that chemotherapy is often not so systemic chemotherapy, not so absolutely effective in peritoneal carcinomatosis. So that's this all shows the high medical need. And then as oncologists, we believe in a multidisciplinary treatment. We think we could only tackle this problem in a multidisciplinary team. That's why we have chosen the best available systemic chemotherapy at this time. And this was the EOX regimen. Sorry. To cut out my cough then in the afterwards. And I have to bring this a little. Sorry.
Do you have a virus? You have to have to press Alt and Delete.
So the EOX regimen, I mean, this was tested in a big British trial, the REAL-2 trial, which compared the old ECF with cisplatin 5-FU to oxaliplatin capecitabine, and showed that this replacement cisplatin oxaliplatin 5-FU capecitabine can be easily done. And in this trial, the EOX regimens even seem to be most effective. So that's why we have chosen this. And it's still now the backbone of oxaliplatin and fluoropyrimidine is up to now still the standard backbone of systemic chemotherapy. And then, as Beate mentioned, we had to do an amendment for the HER2 positive patients, because at the time the study really got going, we knew that for HER2 positive patients, we have to include trastuzumab. That's why we sort of amended the trial for HER2 positive. And again, our belief, to sum it up, is that we could only tackle this difficult problem of peritoneal carcinomatosis with a multidisciplinary regimen, with the best from the oncology side and the best from the surgical side.
Okay, so now coming to the principal objective of the study. As you know, at this point of time, we had no proof of the benefit of cytoreductive surgery in the management of peritoneal metastases from gastric cancer. And the research question that you asked was to compare cytoreductive surgery and HIPEC versus cytoreductive surgery alone. Why did you not choose CRS and HIPEC versus systemic chemotherapy alone, which is considered by many oncologists in Europe as the standard of care?
So who do you ask, me or Beate?
Maybe you, Peter.
Okay. Now, of course, the other trial would be also a good design to check the combination cytoreductive surgery plus HIPEC against systemic chemotherapy. That's another sign. And as you know, other trials are currently investigating exactly this question. But we decided to sort of cut pieces of this off and especially concentrate on the benefit of HIPEC. And in some respects, this was also a pragmatic approach, because, as you know, even our trial was very difficult to get patients to agree on, and the two arms would be even more different if one arm gets surgery, the other arm gets only in marks. Chemotherapy would have been even more difficult to convince patients to participate. So there's also a pragmatic component to this. And I think it's on the other hand, it's not bad to really investigate the HIPEC part on its own.
And I also must say that in the meanwhile, there were no randomized trials, that's true, but there were a lot of trials that demonstrate that if you have a cytoreduction, so removal of primary and metastatic disease in a curative intent, these patients had better results than chemotherapy alone. Compared. So this is not randomized trials, they're not so good to discuss, but anyhow, there were some hints. So we decided to say, well, and also during this time, HIPEC was coming up, HIPEC everywhere, HIPEC in the morning, HIPEC in the evening, HIPEC everywhere. So this was just something to look at, is HIPEC really something strong, powerful treatment, additional treatment to overcome recurrence of the disease, and is able to influence disease-free survival. So there was a lot of unbelievable, it's not possible, we do it, and then we show that it is not possible to get with HIPEC something positive. But at the end, as you know, we had a positive, significant result. So this was something which was behind. To prove per principle, is HIPEC a strong, powerful treatment in a very, very bad prognostic peritoneal metastatic gastric cancer.
Okay, so now what about the timing of the randomization? You decided to choose to randomize the patient after the diagnosis of peritoneal disease, whatever the PCI was. We know by your study that 17% of patients had in each arm a high PCI, more than 13, and nearly half of patients PCI less than 6. What are your comments, Beate, on the timing of this randomization? As you know that most of the trials that evaluated HIPEC did the randomization after a complete cytoreductive surgery. Of course, it allows you to evaluate the impact of neoadjuvant systemic chemotherapy on the disease, but why did you choose this time of randomization?
So I think this is quite easy to answer. We had to this time no really trial what PCI, as a randomized trial, what does it mean? And what we did, we stratified by PCI. We had PCI groups. Yes, we know, and we realized, of course, if you have high PCI, if you have a big tumor burden, it's always the same. You have a not so good prognosis. But somehow it also can exist that if you have a PCI about 16 and you are able to remove nearly complete, is possible. And then additionally HIPEC, perhaps this can do something. in these patients. And what we have to realize and have to learn that there is, of course, similar to the PRODIGE 7, that is, of course, in the higher group of patients, the additional HIPEC treatment is effective, and we also realize this. And of course, we have a preoperative treatment, and this can also perform a response to the treatment. And we also treat these patients. They have they had in the first front a PCI of 17, and they were stratified by a PCI of 17, but then they had chemotherapy and had a PCI of 9 or of 8 or something or less. And but this was something which was also important. So therefore, it was not excluded. We just wanted to have all the patients in, and then we can have a look first on the response of systemic chemotherapy. We also have the possibility to look at the toxicity, the side effects of systemic chemotherapy. We have the situation to look for the problems by surgery due to tumor burden, whatever. And we had also the possibility to look whether HIPEC is not or improves complication, what it does not. So we can answer a lot of questions with including these patients. And of course, yes, this is only possible if you have educated cytoreductive surgeons who say, oh, well, no, it doesn't respond, it's still 17, it's no way to do, and it's not possible to do so. They are also included, and this was always between Peter and me. It is not progression, but it is perhaps just not responded to the treatment. So this was something,
Okay.
Yeah,
so
just adding a little bit to the timing of randomization. You know, as Beate mentioned, we wanted to check the multimodal concept. Yeah, because as I mentioned before, the only step forward is in a multidisciplinary team. And so that's why we want to include the whole multidisciplinary team into this trial. That's why we didn't randomize these highly selected patients who receive a cytoreduction of 0. This is one point. And on the other hand, you know, in the current, at least German S3 guidelines for oligometastatic disease, the direction is that you don't operate on all patients with oligometastatic disease, but those who are treated with a chemotherapy and have at least a stable disease or even a response to chemotherapy. You know, this is a biologic parameter. If the patients under chemotherapy progress and develop liver metastases 3 months later, this patient wouldn't have any benefit from cytoreduction surgery upfront. So these are aspects regarding your question for the timing of randomization.
Okay, and one question regarding your inclusion criteria. You decided to exclude patients with a positive peritoneal cytology, and we all know that, especially in the Japanese classification, positive peritoneal cytology is considered already as peritoneal disease.
Yeah, but that's not the case in our European vision. You know, in our guidelines, at least, we know that positive cytology is a poor prognostic marker, but nowadays, up to now, it's not recommended that it influences treatment decision. You know, if you only find positive cytology, you don't change whether you operate the patient or whether you don't put the patient into a palliative setting just because of positive cytology. And as I know, this is the same in the entire Western world, in the US and Europe. It's a prognostic, but no marker for not a predictive marker guiding you for any kind of treatment. That's why we didn't include this.
Okay.
And
what about
just additionally, the type of cytology, there are, I don't know how many different kinds, 200 milliliter, 100 milliliter, only in the upper one, in the distal, then in paraffin or not in paraffin, immunohistochemistry, whatever. There's so many different kinds of getting cytology. And for instance, at the Charite, I tried it several times, and I had so less cytopositive patients that I said, well, Japanese and France, they have a lot of patients with cytopositive. We don't. What does that mean? So that for me, that means that it's just so difficult to get the same kind of diagnostic of cytology. So
okay. And what about the extraperitoneal disease? What about the extraperitoneal metastasis? How did you manage this? Beate?
Well, we had our staging. All patients had a CT scan of thoracic, of abdominal and pelvis region. We excluded liver metastasis. We excluded obvious other kind of metastasis, and only peritoneal metastatic disease was included, with the exception of ovarian metastasis.
Yeah, I mean, this would have complicated the trial completely. I mean, we wouldn't expect any effect of HIPEC on liver metastases. This was not expected. So that's why we didn't want to complicate the trial by including these other parameters which might influence the prognosis but are not affected by our treatment.
And we wanted to focus especially on one item.
Yeah. So now an important comment, I think, on the stratification factors. You decided to identify the PCI, of course, the center. We all know that the big influence of the center in the results, the HER2 status, because we had this targeted therapy. But what about the pathology, and especially the signature cell pathology that we all know that may have a bad prognostic influence, that lead to more peritoneal disease, to perhaps less response to systemic chemotherapy? Why did you not choose this poor prognosis pathology in the stratification factors? And if you would do another study, would you choose this bad prognostic pathology as a stratification factor or not? Maybe you can answer both.
So if you have a lot of stratification criteria, you need more patients to be randomized. This is the first point. And the second point is that, well, it was 80% patients of this trial had signet ring cell cancer because they have the risk of peritoneal metastasis. And HER2 positivity was 10%. This is less compared to normal gastric cancer. And PD-L1 was even less. So we treated really the bad prognostic gastric cancer in this trial.
Yeah, I totally agree. I mean, the stratification factors have to be limited to, and of course, a signet cell, there's a big overlap between signet cell and peritoneal carcinomatosis anyway. And a signet cell, I don't know any randomized trial where they stratified for signet cell histology. I mean, your question would also apply for all the palliative trials with checkpoint inhibitors and all these, then the next question is, why don't you stratify for ECOG status? Because ECOG status is also prognostic. So you have to limit your stratification factors.
Okay. So, unfortunately, even if your study demonstrated a lot of results, you were not able to conclude and to include all the patients that was previously scheduled. Why? What is your interpretation? Is the introduction of the modification of this neoadjuvant systemic chemotherapy with the big demonstration of the new FLOT regimen that really improved the results had an influence? How do you interpret the non-possibility of concluding the level of inclusion?
So that's probably regarding the chemotherapy backbone. That's probably a question for me. You're right. FLOT has replaced ECF in the perioperative setting. And showed in the FLOT4 trial, FLOT showed superior survival benefit compared to perioperative ECF in the curative setting. From the oncology point of view, so that's why many people were thinking of perhaps FLOT is even better with peritoneal carcinomatosis, and some people included patients and just treated them with FLOT. So these were protocol violations. That's why we have this problem in interpretation. So some investigators just have chosen FLOT. But from the theoretical scientific point of view, it's with peritoneal carcinomatosis, we are in a palliative setting. You might have long-term survivors, but to be honest, it's a palliative setting. And in the palliative setting, it's not proven that a triple chemotherapy, up to now, it's not proven that a triplet is better than a 5-FU oxaliplatin-based doublet. And there are a big Japanese trial in the palliative setting investigating this question, and it showed exactly the same survival with a doublet compared to a triplet. The last ASCO, there was a French trial, you probably know, the GASTRIPEC trial, which seemed to show a survival benefit for a triplet. But there's still a matter of debate whether really a triplet with a taxane in the palliative setting is better. So to sum it up, some investigators had the opinion that FLOT might be better in this setting, but we didn't do an amendment because there is no real proof that with peritoneal metastases, the triplet is really proven better than oxaliplatin, capecitabine-based, any oxalicate-based treatment.
Okay. And to stay in the problematic of this neoadjuvant systemic chemotherapy, in your study, just over half of patients progressed under neoadjuvant systemic chemotherapy. Is it for you the real reflect of the response that we may have by using neoadjuvant systemic chemotherapy, or do you think that we may have more response with other regimens than the regimen you choose?
Yeah, that's a question Beate and I don't quite agree on. So I start my point of view. I think it's also, I mean, we know that chemotherapy is perhaps not so effective in peritoneal carcinomatosis. So there might be the number of patients progressing under chemotherapy might be higher than with patients with liver metastases. On the other hand, I think there is also a staging problem. Peritoneal carcinomatosis, you can't stage easily by a CT scan. And I think just by laparoscopic investigation to really decide whether this is a clear progressive disease. Even you know, it might sometimes there is some not so some unclear area in this. And then extrapolating further, you mentioned that perhaps we need to even more improve our chemotherapy. And that's, of course, totally right. And there is loads of things happening in the moment with checkpoint inhibitors for PD-L1 positive patients and HER2 combined with checkpoint inhibitors, trastuzumab plus a checkpoint inhibitor. And now we know that Claudin 18.2 is also an effective target. So there's loads of things happening. And nowadays, the best chemotherapy would be even more personalized in future trials. And we might even have better effects on peritoneal carcinomatosis.
Okay. So we all know how it's difficult to evaluate the response to systemic chemotherapy when we have peritoneal disease, especially for gastric cancer. Beate, what about the evaluation by redo laparoscopy just before scheduling the surgery? And why did you not choose to standardize a new laparoscopy before the surgery? And more generally, do you think that we should work on a new tool to evaluate the response, incorporating two laparoscopy, one before neoadjuvant systemic chemotherapy and one after?
So in the GASTRIPEC trial, this was the case. We had every patient has to be evaluated by PCI stratification criteria and the biopsy of the peritoneal business. So there was always a laparoscopy upfront any inclusion criteria for the trial first. Second, before the surgery, we always do, and also here, a laparoscopy. We just start with a laparoscopy and see, is there progression or not? Because we always have a 30-second video from all our patients. And then we can have a look what was the case in 3 months ago. And then we have a look what is happening now. And we have the videos. And I think I just got the idea. This is something we can do together. We put all our videos on a platform, and we can look whether you and I have the same opinion of response or progression disease, and have a look of the outcome of the patients. So if this is possible to have a clear opinion via laparoscopy, if it is progressive disease, or is it a stable disease, or if it is responding to the treatment. And I think it is possible to see. And for this situation, we also have to think a little bit what we are telling our patients, because the peritoneal metastases do react on systemic treatment. Well, pseudomyxoma and belly jelly will not, because they have no contact to the peritoneal surface. But the ugly gastrointestinal tract peritoneal metastases, they have a micro environment, and they have a blood supply, and they can be treated by systemic chemotherapy. And you see this. It's getting flattening. It's getting shiny, and if you have a biopsy, then there's no tumor anymore visible by the pathologist. So we can decide whether we have progression, stable, or response to treatment via laparoscopy and via documentation. Okay,
and what about the rate of complete cytoreductive surgery? You had approximately 70% of patients that was operated with a CC0, CC1 resection. as it was not allowed to cancel the surgery if even in case of CC2 cytoreductive surgery. Can you comment on it? Because usually the selection of the best patients for CRS and HIPEC are patients that should be treated by a clear CC0 resection.
Yeah. So for the GASTRIPEC trial, there was the indication for if the surgeon was able to remove 80% of all tumor, then he was able to do so. However, this was not what people did. They did more than 80%. They said, well, if I can remove at least 98%, then I will do. But this is not a CCR0. And for gastric cancer, to get CCR0 or gastrointestinal cancer, to get CCR0 for a PCI above 10 is usually, in my eyes, not possible, because you always will oversee some small nodules from 1 millimeters and you cannot remove. And therefore, I think therefore is HIPEC staying. HIPEC has to do something. HIPEC is, if you remove everything, what HIPEC should do then. There is nothing to help HIPEC. HIPEC cannot close peritoneal channels or something. HIPEC must do something. So I guess it is a quite good indication, and this was the same what you saw in the Project 7. If you really have a low PCI, then the possibility to have a complete resection is much higher. Yeah, of course, because then perhaps there are 3 lesions and that's all, and you can remove them and you don't see anything anymore, and that's it. But not if it is a PCI above 10, I will say, more or less. And but there you also see an impact of HIPEC if you have at least a little bit left, we'll say. So might be this is something which we have to discuss. So cytopositive only means that you of course will have a complete cytoreduction, because no cytoreduction was necessary, because you just have cytology. But so what should HIPEC do in these patients? Yeah, perhaps this is something what we have to discuss, but this was not, CCR0 or CCR1. This was not an exclusion criteria. This was allowed. So 80% was allowed, but this was not the aim of resection. I think they were all 98% something. Some of them, okay, yeah. There were some where you resected because stenotic tumor comes together with everything. Yeah.
Okay. So maybe you can both comment on the HIPEC regimen that you choose. You choose the combination of mitomycin C and cisplatinum without the use of sodium thiosulfate, because I think that at this point of time we had no demonstration of the effect, but you did not report major renal toxicity with this protocol. Why did you choose this protocol, and can you comment on it?
So for this was in former times the protocol which we also choose from Paul Sugar-Baker, and we just assumed this as a good drug. Mitomycin and cisplatin both are good for the situation for gastric cancer, and therefore we had no exclusive discussion not to use the both of drugs. And in former times, I must say, we had also another anesthesiological program. At the moment, we are very, very low in fluid given. We give more or less a fresh frozen plasma, try to avoid fluid infusion. And in the former times, we just had a lot of fluid. But also for gastric cancer, this is not a cytoreduction for mesothelioma or pseudomyxoma. It's a surgery. If it is possible to have a cyto in gastric cancer, then it is not a 10 hours operation. It's more or less a 5 hours operation. So there is not the fear, or we don't see it that we had acute kidney failure or that we had a higher amount of raised creatinine or something like this.
Okay. So maybe a question for you, Peter. A comment on the median time to restart the adjuvant systemic chemotherapy. The mean time was in your study 53 days. What do you think about this time? Is it correct? Is it the reflect of the true life? And we all know the potential influence of the RIOT in the results. And do you think that this relative long delay may have a negative impact on overall survival and progression-free survival?
Short answer, no. long answer. No, I think we are totally in line with all the other trials, for perioperative chemotherapy, the ECF MAGIC trial, the timing of the post-operative chemotherapy in the trial, it was at 6 to 12 weeks after operation. And from my practice, which I treat many patients, there's hardly anyone you could start 6 weeks after a gastrectomy with chemotherapy. And if you start too early, it's no benefit, because then you have to wait 2 months before you can get the next cycle, because the patient was not fit enough for the chemotherapy. So with 53 days, it's surprisingly close to all the other trials administering post-operative adjuvant chemotherapy. So I don't think that this is any bias or negative effect. I think it's totally in line with our experience.
Okay. And regarding the perioperative systemic chemotherapy, has only 60% of your patients really had adjuvant systemic chemotherapy, and as only half of the patients can do the overall perioperative management. What do you think about the number of cycles before surgery? Should we do less? Should we do more to get more down staging? What is your advice regarding this management?
Yeah, I mean, if we compare these data again to the perioperative trials, we are still totally in line. In the MAGIC trial, 42% of patients received all post-operatively planned chemotherapy. In the FLOT4 trial, it's about the same, that 40 to 50% could receive all planned FLOT treatments after the operation. And even the most modern trials, the Keynote 585 with pembrolizumab perioperative, they all have sort of data like this, that you can't give all planned post-operative treatment. And of course, the question is, so should we not move some of the planned post-operative treatment to the pre-operative setting? That's a good question. And there are no trials in the curative setting investigating this yet, but they are planned. And I think it's probably a good idea to give more intensive chemotherapy before the operation, and even with all these personalized targeted agents, and then do the operation and just give perhaps one additional cycle post-operatively to catch some circulating tumor cells, perhaps. So I think that's probably a good idea for the future. But we wouldn't, in our trial, we didn't want to change so many parameters. You know, we wanted to be similar to the MAGIC trial, 3 cycles before, 3 cycles afterwards. And you know, if we had other results, we wouldn't know whether it was due to HIPEC or due to the change of the chemo regimen. But in future trials, you are right. This is might be a good idea.
Okay. So now what about the very good results that you get for HIPEC in the specific subgroup of patients that were treated by a CC0 resection, so by a complete macroscopic resection? This is, of course, in line with the results published by our French group, the CytoShip trial, also in Journal of Clinical Oncology. What do you think, Beate? Do you think that this is another argument in your study to select for this kind of procedures only patients that can be treated by a CC0 resection, and how your study had one more argument to do this combined treatment for patients accessible for a CC0 resection?
Yeah,
Beate.
difficult question, because I think that CCO might be, if we have a randomized trial, if you have only CCR0 and CCR0 plus HIPEC, might be not effective. I'm not quite sure, because HIPEC has an additional power, but for peritoneal metastasis, if you not can remove everything. I'm not quite sure. We could demonstrate CCR0, yes, and we didn't see anything in this. You know, in this patients group, we had laparoscopy, and some of them could have been were able to resect, and some of them were not able to resect. But they were randomized in the HIPEC group and received HIPEC. And then, because of progression, got out of the trial. Mm-hmm. Yeah, so we have patients who were not resected due to big burden of tumor, but because of randomization, received HIPEC. And they were all included by the results of the progression-free survival. And the progression-free survival, the HIPEC arm was significantly better.
Mm-hmm. So you.
I mean, I agree to Beate. I think the data are not so clear that HIPEC is only effective in the last left cells, in the micro metastatic situation where you have received a CC0. You know, I would, in future trials, I would still like to see the group with left peritoneal metastases. It's not because peritoneal carcinomatosis, we are not really in a real adjuvant setting where we have the good aim for cure. I mean, it's my oncology point of view. It's a metastatic, it's a palliative setting. We are aiming for long-term disease control. And so I think time is not right to already to exclude patients with macroscopically left peritoneal carcinomatosis from future trials. That's at least my point of view.
Mm-hmm. So, but it will lead to another questions. It will say, we would say that so a CC2, CC3 resection could be recommended in combination with HIPEC in a palliative setting. Because if you allow to do HIPEC with incomplete cytoreductive surgery, you will operate some patients that you are not able to completely resect. Do you think that this message should be delivered? Personally,
I mean, we wouldn't give this message outside of a clinical trial, but it would be interesting to get data for those patients. I mean, you probably agree, but only inside of a trial. I wouldn't give this message out to the public that you can operate everybody and it doesn't matter how much you leave inside, you just give HIPEC. I mean, that's not definitely not the message we can give right now.
Okay. So
because Olivier, just the comment. There are lots of surgeons who just bombardement of the abdomen, yeah, and this is then debulking, yeah, something like this. And of course, they have pancreatic fistula, anastomotic lesions, whatever you want to have, and patient will die. So if you have an incomplete resection, the margins must be safe, the anastomosis must be safe, and of course, if you have some lesions in the distal abdominal somewhere, discuss, but the main operation should be safe. But this is only possible in surgeons who are really educated in these difficult patients to operate them. It's not easy, and it's not surgery for a non-center, never.
Okay, so the next study, if we have the courage to conduct, what do you think it's important now to answer to the question and to compare CRS and HIPEC to systemic chemotherapy? Do you think that this kind of study is realistic in Europe? Do you think that patients and surgeons would participate to such study? Is it the principal question today?
So for me, I think what is important? I think important is a preoperative treatment, which has to be defined. It could be FLOT, it could be this, it could be that. The last generation of best kind of chemotherapy coming from randomized trials, whatever, changing during your trial, which is running. Yeah, this might be possible. It should be included. It should be included that the last day of preoperative chemotherapy to the interval to the surgery must be at least, say, 60 days, but not longer. Otherwise, patient is not possible to be included in the trial. So this has to be limited and defined. And then, of course, I think you need stratification. What we said, to have low PCI, high PCI, middle PCI. Then patients will be not resected or will be resected, respond to treatment. I don't know what happens to them. Do you just have to rely on the consciousness of the surgeon that he's able to define whether this is possible to resect or not? Might be that we have to do something like the Dutch have done, that the centers who are included have to be scheduled by the experts, whatever, to have the same idea that they send us the videos, whatever, to get a good, reliable situation. Why not? And then for me, try to have to define what kind of HIPEC drug This is very difficult.
Yeah.
Sure. But this
So,
has to be
regarding
discussed.
regarding the choice of the HIPEC drug, the recent Delphi process that we did was in favor of the HIPEC regimen that you choose. So even if it's not already published, it was also the combination of mitomycin C and cisplatinum for 90 minutes. So, Peter, one comment of this next study that we should work on the regard of the medical oncologist. What is today for peritoneal metastasis the principal question?
Yeah, it's difficult. I mean, all these trials stop early because of poor accrual, and it's on the one hand you want to make an ideal ideal study, really clear and clean, with very well-defined inclusion and exclusion criteria. But on the other hand, you have to be pragmatic, because the best studies are no use if you have to finish them early. And in Germany there was this from the AIO, the Renaissance trial investigating oligometastatic disease, and it was well-defined oligometastatic disease and limited peritoneal carcinomatosis as one single factor was also a possible inclusion. But even this trial, which had a very broad inclusion criteria, had to now be stopped because of poor accrual. There are many patients in, so we still hope that we get some good results. But even with such broad inclusion criteria, it was very difficult to make it. So I think we have to, on the one hand, we have to be scientific, but on the other hand, we have to be pragmatic. And all the other trials for peritoneal carcinomatosis, they are only done in one country. Perhaps one should start an international initiative and convince all the French, the Dutch, the German, the Scandinavian people to agree on one trial to really check whether HIPEC and CRS are of benefit. In the oncology community, from medical oncologists, so far they are not really convinced that this is a proven tool. And our trial, we come to our take-home messages soon, and our trial, I think, shows that there is some additional value of HIPEC, but it's on the other hand, it's not so scientifically founded that we can convince skeptics about this.
Okay. And today, with the progress that we did in the perioperative management, in the detection of some new targets, with the development of immunotherapy, if you would do again this trial or another trial on gastric cancer with peritoneal metastasis, the choice of the main principal stratification factor would be what? What is today for you in this area the principal stratification factor? Are they different than 10 years ago, or are they the same? Peter?
Yeah. The stratification factor, you have to do prognostic factors. I don't think that you have to stratify for all the different kinds of chemotherapies, because if the patient is HER2 positive, you can give him nearly the similar prognosis when you start this target. You treat this target with trastuzumab. And if the same for PD-L1 expression on its own is not any prognostic marker, it's a predictive marker, predictive for the benefit of immunotherapy. So I think in the moment that the stratification factors would be not so different from earlier trials. Of course, the systemic chemotherapy would be much more personalized, but you can't stratify for all these different biomarkers we have now.
Okay.
But perhaps response is a good stratification parameter. We had not used response so far.
Yeah, that's a very good idea. That we have to, in a future trial, we have to include the preoperative treatment and see the responding patients, and stratify for response and stable disease, and those who progress, we have to exclude from further surgery.
Okay, and Beate, if I understood well your argument and your interpretation, so as you know, there is in Netherlands the Periscope trial that decided to select the good candidate, what they consider as good candidate for such aggressive management, and they decided to limit their inclusion criteria to patients with low PCI, with PCI less than 7. So in your mind, you think that we should continue to try to investigate this kind of combined procedures for PCI more than 7?
Yeah, it is a trial which looks for cytoreductive and HIPEC versus chemotherapy alone. This might be really interesting to convince our oncological partners, because they unfortunately have no clue for PCI, low, high, not. They know what it is, but they start chemotherapy without knowing. And therefore, they just start as metastatic disease, all fits one. And now we have we can offer our partners very well diagnosed patient in a metastatic disease. And we have to look, perhaps this might be good for the patients. I don't know, could be. That patients, they were not operated, they had no symptoms, they respond, they might be that they don't need surgery. We don't know this yet. We as surgeons, we have the tool of laparoscopy. It's for us, it's easy to stratify by PCI, by all these things, and the poor oncologists just treat metastatic disease without really have no RECIST criteria for peritoneal metastasis. Will not do, cannot, do not have, and this is really difficult. Perhaps this is a very interesting trial to find out whether oncology and surgical oncology, or medical oncology and surgical oncology, should stay together from now on to get the same vision. Perhaps we have to treat together, or the oncologists in this setting are much more effective, and patients don't need surgery if they have no symptoms. So this is fair, I guess. This is fair.
Yeah. So it was not the subject in your study, because you treated patients with surgery in both arms, but we didn't speak at all of quality of life. And I think that regarding the management of peritoneal metastases with gastric cancer that include gastrectomy, that have a strong impact on digestive quality of life and quality of life at all. So what do you think in the incorporation in future studies of this quality of life evaluation? And Did you do some quality of life evaluation in your study?
Every patient got preoperative, pre-treated quality of life after finishing preoperative treatment, after surgery, and after 6 months, and so on. So, but there was no difference in the two arms. But this is, we will publish this additionally, but this was too much for this kind of, yeah.
Yeah, okay. So
yeah, coming back to your question, which patients to include in future trials. I mean, it's difficult. On the one hand, data are not so robust to really tell which patients benefit from HIPEC. It's not proven that those with higher PCI don't benefit. Perhaps those also have an additional benefit. You know, it's an unanswered, not a really answered question. But on the other hand, if we look at the direction how guidelines develop, we know that debulking surgery for gastric cancer is not effective. We know the regatta trial in the Asian regatta trial where they just debulked the disease by taking the primary tumor out, and this had no benefit at all. So it's on this way of argument, it's quite understandable to limit the operation to those where you can remove all tumors to a kind of R0 resection or CCR0 resection. You know, because with the aspect of quality of life, we don't have to forget that if we operate, we impact quality of life. So.
Systemic chemotherapy and intraperitoneal chemotherapy using PPAC, using HIPEC, using so do you think that if we control the disease for a long time by using one or two this bidirectional chemotherapy, and if you have a limited disease, could be a selection process for the good candidate of surgery?
Yeah, exactly. That's a very good idea. And I think there are trials even trying to explore this bidirectional treatment, giving a drug systemically and the same drug intraperitoneally. Yeah, there's still loads of opportunities for future trials.
Okay, I think that, and I'm sure that, you know, Jimmy So from Singapore is trying to establish a new international study that will evaluate this impact of the conversion surgery with or without this intensive neoadjuvant management that could combine systemic chemotherapy with all the modalities of intraperitoneal chemotherapy, and with, as you underlined, Beate, a real and good evaluation by laparoscopic approach of the peritoneal disease, which is probably one of the key for the selection process, with the response, as you mentioned also. So now perhaps to conclude, if you will have both, I would like to ask you the 3 main messages that we should take from the GASTRIPEC trial. And I think it will be important to have the surgical oncologist point and the medical oncologist point. And we will start, of course, with you, Beate.
Thank you. So for me, a main message is, first, it is possible. It does not, HIPEC does not improve complications or something like this. So HIPEC adds at least only beneficial situation, at least for progressive-free survival or disease-free survival. This was significant in this situation for HIPEC patient. It was not significant for our aim point. So second point I learned, in palliative or in metastatic randomized trials, the first aim should not be overall survival, should be progression or disease-free survival. Because we have a lot of new drugs coming along the way while we perform the randomized trials, and then they get additional treatments and whatever, some get not, whatever. It is not documented anymore because we are not allowed to do this. So this is the second thing I learned from this trial. The second is that it is that we also learned that systemic chemotherapy is not always helpful. We have progression, we have stable, but we have also response, which means chemotherapy does change peritoneal metastasis. This is not that systemic chemotherapy does have no additional situation on on the metastasis side. So it is same like in liver metastasis, same like in lung metastasis, and we also have an influence by systemic chemotherapy on peritoneal metastasis. And the fourth is that because that is the case, we have to convince all surgeons and all oncologists that before they start any kind of treatment, please perform a staging laparoscopy and have a video to compare after 3 months. This is my message from the trial.
Thank you, Beate. Peter?
Yeah, my take-home message, I mean, as we sometimes talk to Beate, so our messages are not so different. So that to say from my point of view, I mean, this trial, I think, definitely shows that HIPEC has a positive signal and has some benefit, yeah, in some groups. But it's not that HIPEC is ineffective. It has some benefit, and this is message number one. Message number two, it's that we have to define the subgroups of patients in whom we really show this benefit, that it extrapolates into a significant benefit. So message two is we have to define subgroups. Message three is that in future trials, we also, on the other hand, have to be pragmatic too, and that we really can complete a trial. It's no use starting a next HIPEC trial, which has to be terminated early because of poor accrual. So we have to get all people involved, that they are really 100% behind the next trial. And the last message is that in future trials, we can only tackle this difficult disease, peritoneal metastases, if we use the best of all disciplines we have, the best and most modern systemic treatment, and the best intraperitoneal treatment, and the best staging, most defined with the laparoscopic experts, and of course the best surgeons. You know, and I left this main message with the best surgeons as my last words.
With the best medical oncologists. I think that we can conclude this. I would like to really thank Aditi Bath that make it possible. And with so, I hope during this 1 hour and a half, that how it's important to discuss around prospective randomized trials, even if there is a lot of the informations that we discussed in your paper that was published in Journal of Clinical Oncology. But it was interesting to see what are behind And in front of these messages, and I will congratulate you both again for this very important data that will allow all of us to progress more and in the management of this difficult disease. We saw how it's difficult to manage peritoneal metastasis, but we saw also that we should manage them, because we really can improve their prognosis, their quality of life, and thank you for that. So thanks for all, and see you soon.
Yes, hopefully in Hanover.
Thank you very much from my side.